she has now an experience of what we call a resource patient resource, or a resource patient. I don't okay. And she had an education about these topics, and she was co-founding Preface, which is a collective group to have to give the word to the patients suffering from this disease, and to try to incorporate the patients into recommendations. So, Christele, you have 30 minutes. Thank you.
You hear me? Yeah?
Yes, it's okay.
Hello, everyone. Thank you, Christian. I'd like to thank you for inviting me as a patient, and especially you. It allows me to offer another perspective on the doctor/patient approach. Many studies have already been published on patient results and patient engagement. I'm not going to give you a scientific presentation, even though I'm going to draw on several articles in the literature. And instead, I'm going to try and tell you the story of patients seen from their own perspective, and try to inspire you to work with patient results. Okay. So, do you know why a tango is unique? Because it takes two to tango, you know. And why the tango? It was Dr. Gabriel Sarah who reminded me of this image. Dr. Sarah is an oncologist and a hematologist at Mount Sinai Roosevelt Hospital in New York. And is a pretty amazing doctor with a great humanity. And he likes to make this association of ideas and brings tango dancers to his department, where he treats complex pathologies and, unfortunately, often the end of life. And this approach is so accurate and moving that it recently inspired a French film, which is called Peaceful, de son vivant in French. And Dr. Sarah plays himself in the movie using music and dance to establish a human relationship with the patient. And he says the doctor is interested in the individual behind the patient, and the state of mind of both will change over time. People change over the course of their treatment. Their moods and emotions are not the same from one week to the next, or even from one day to the next. That's why I call dancing with the patient, and the tango sequence in the film symbolizes this close relationship between us. So tango is beautiful, but it's a difficult dance, and it requires you to trust the other dancer, to be connected to your body, to your reactions, to your movements. One false step can cause the dancers to stumble and fall. That's what being partners is all about, and it's exactly the same in medicine. And with the patient, we dance together. That means we hold hands and look at the illness together. And together, we're going to find a way to destroy it when we can, or to live with it if we can. So this movie is pretty amazing. And if you haven't already seen it, I highly recommend you to see this film about the doctor/patient relationship in the context of illness and the end of life. It is absolutely awesome. So, taking the patient experience into account is a recent approach. What can you see in these photos from the 19th century that you know so well? Apart from the fact that there are very few women, but that's another story, we see demonstrations on patients, consultations in public where the patient is staged, where he or she is the object of study and care, but without his or her voice, point of view, or experience being taken into account. According to the work of philosopher Alexandre Klein, a new figure of the patient emerged during the 20th century, accompanying the transformation of modern medicine. And this evolution has been facilitated by laws, like in France, such as the 2002 law on patients' rights, followed by the 2009 law. However, the changes we are witnessing go far beyond the scope of these laws. And from social demands for a lay conception of health to the creation of an alternative medical science, a whole culture of autonomy has emerged, and that is now shaping both the practice and the future of modern medicine. But in fact, patient involvement in the healthcare system is nothing new. You all know the Alcoholic Anonymous, but do you know when these were created? It was in 1935 in Akron, Ohio. And it was the result of a meeting between Bill W., a stockbroker from New York, and Dr. Bob S., a surgeon. They were both inveterate alcoholics, and they launched together the first support groups. The rest is history. There are now groups all over the world, and it was the real beginning of patient engagement. In the same way, the practice of peer support developed throughout the 20th century in the field of disability, whether it's mental or physical disability, and you can read, for instance, the books of F. Gardner about it. But the real revolution in patient involvement came with the AIDS epidemic. It gave patients the opportunity to become active players, not only through their medical and political demands, but also through their involvement in research. What was it about? In the mid-80s, a whole generation of doctors was confronted with the twin realities of, first, the vulnerability of the human condition, and second, the fragility of medical power. In fact, these patients who were about to die showed a real expertise in public health. They helped shape public policy and prevention. This led at the time to this quote, "Patients are not the problem, they are a part of the solution." And I think it's the best definition of patient engagement indeed. So what was AIDS about the time? It was like 18 months of survival and loss of sight before death. It was a situation of technical powerlessness, and it opened many doctors and nurses up to a different way of caring. Unable to cure the patients of AIDS, they were able to call on other care resources. And for the first time, strategy would change. Doctors would have access to a wealth of information from public health experts. They were made aware of the problem by what their patients had to say, and they were even approached by the new partners, such as patient organization. By listening carefully to the patient, doctors would gradually discover other wounds, exclusion, stigmatization, and social inequalities in front of the disease. And Vincent Leclerc, a theologian of vulnerability, gives us some keys to analyze the new role of patients. To meet the real needs of patients affected by AIDS, we need to listen even more to patients and their families. And it is important to see them as the real players in the epidemic and not just as victims. The most vulnerable are in the best position to understand the realities of the pandemic, the constraints to be taken into account, and the material, psychological, and social consequences of the disease. It is therefore with them that we must constantly seek new strategies for prevention, care, and support. So defending the rights of the most vulnerable, therefore, involves a strategy of empowerment. And the AIDS epidemic also led to the development of the first major studies on patient compliance, because it was thought that some patients did not deserve treatment because they were not compliant enough. Because 95% compliance with the treatment would be required. So the way we think about the care system has changed a great deal through AIDS, and especially with the involvement of patients in the system. As a result of this, over the last 20 years or so, a new way of thinking has emerged, some theories on the place the patient should have in the system. A lot of care facilities have thought about it and said, let's put the patient at the center. But at the center of what? In 2014, two psychiatrists from Geneva, Stiefel and Canuto, warned us against this patient-centered vision in an increasingly standardized healthcare system. Because with the promotion of evidence-based medicine and the introduction of economic rationality, don't patients find themselves at the center of paradoxical injunctions, just like their doctors? Are they really able to optimize their treatment and make their own decisions? That's a good question, and some universities worked on that concept to think a little differently. The vision of the patients themselves is a little different. I would like to share this drawing by Laura Arnal. Laura is a patient resource for the collective preface and author of a book on Lyme disease. And she describes this concept a little differently. The one who is in the center doesn't necessarily have the best place. And there is often a confusion between a person-centered approach based on Carl Rogers, who talks about active listening, believing in the person's potential, his resources, and how a team decides to organize itself and places the patient at the center without often including him, which is anything but the person-centered approach of Rogers. So to take up the idea of drawing, the aim is not to be the main course, and but to be all around the table and as a patient be integrated in the team. A third approach has emerged in recent years involving the integration of patient results into research and in the healthcare system. We will now focus on another perspective on the role of patients based on the study conducted by Marie-Pascale Paumet in 2020. And it's called Developing Recommendations for the Diagnosis and Treatment in Life of Lyme Disease, the Role of the Patient's Perspective in a Controversial Environment. I will rely on this study to show all the interest of integrating patient results in the development of recommendations for good practice, but also in research. In this study, the development of good practices in the management of a controversial disease was greatly facilitated by the integration of patient results throughout the work. I will come back to this a little later. And in all the above observations, what objectives have been achieved by integrating patient results in the system? It's bring a unique experience that does not exist in the literature, integrate active partners in healthcare, help to raise the skills of other patients, and improve overall health outcomes. So what was the context of the study? It was the Ministry of Health in Quebec requested the National Institute of Excellence in Health and Social Services, the INES, to produce clinical and implementation recommendations for the prophylaxis, diagnosis, and treatment of Lyme disease. Just as we do in France too, with the High Authority of Health, la Haute Autorité de Santé. Marie-Pascale Paumet wanted to document and analyze this new process to produce recommendations. She therefore chose to launch a parallel study to observe and analyze the development of these recommendations, where patients had been included in the team of doctors and experts. And the objective of the study were describe the process of trying different modalities of patient engagement as a means to integrate a diversity of patient perspectives, and describe the learning process of INES, the National Institute for Excellence in Health and Social Services, regarding the integration of the patient perspective. And the results were indeed very interesting. It has been demonstrated that the patient partners, patient results, that's another term, influenced decision by sharing their experiential knowledge. The patient interviews and the literature review added an in-depth perspective on the disease and experience with the healthcare system. And moreover, the patient association members shared their perspectives and helped disseminate the recommendation to sustain a practice change. In the verbatims that have been reported from doctors and experts, we find, for example, I was glad the patient partners were present at all the meetings, the doctors say. Definitely, this is the project I've learned the most from in my career, the doctors. It helps to have a democratic and transparent scientific process and to make sure the recommendations are accepted by everyone. And this one is the most interesting, I guess. It's the case study illustrates that including patient partners on the advisory committee is a way to gather and integrate knowledge that is not available in the scientific literature. And the patient partners also acted as a bridge between the patient association representatives and the Lyme project team by being able to describe each person's role and the complementary nature of their respective perspectives. So we can conclude on that study by saying that it was a major step towards developing care recommendations adopted by all. And it would be interesting to use this results more widely in France, for example, by including patient results in the development of recommendations for good practice. In theory, this should be the case, but in practice, it isn't for the moment. Results patients help caregivers to better understand patients in general, but the obvious question is, how do patients develop their skills? The work of Lenise Pereira-Popolo and Catherine Tourette-Turgis shows that patients with chronic illnesses do real work every day to keep themselves alive and healthy. They do self-diagnosis every day. What kind of pain do I have? They do self-prescribing. Do I take a painkiller or not? They learn to carry out actions on oneself, like injections, care, technical assistance. Self-influence. For example, I need to accept the idea of a new treatment and think about taking it, etc. Patients are workers and they learn technical and relational skills. It is this daily work in the chronic disease that enables the patient to later provide information to the doctors and other patients at the start of the disease. The final tick-borne disease working group report reflects patients' contributions. In addition to Canada, there are also examples in the USA of patients being involved in the decision-making process. More than 2,000 patients made written comments to the working group over the 6-year period, and more than 200 offered verbal comments during public meetings. The following themes were expressed most frequently and by a wide variety of commenters. For instance, need for clinical education, clinical reliance upon geographic endemicity, personal sacrifice and loss, etc. One of the doctors commented and said, including patient representatives at the table, put them on an equal footing with others and the panel allowing for more balanced discussions. On the basis of all that work, we can define the impact of patient involvement in the healthcare system. For the doctors, it's a better understanding of the patient's perspective, improve the doctor/patient relationship, developing genuine collaboration with patients, reduce misunderstandings and tensions, etc. For the patients, the works and studies show a best recovery, an increased self-esteem, empowerment, of course, developing new skills, better understanding of caregivers' work, and less hesitation to confide in doctors. So, what could be the roles of patients in the health system, in the healthcare system? We often first think of including them in therapeutic education, but there are plenty of other options. For the record, therapeutic patient education is designed to help people and those around them to maintain or acquire the skills they need to take better care of themselves and live better with their chronic illness. This slide shows examples of patient roles. For example, patient educator, patient teacher. You can be a user representative. There are a lot of words: expert patient, patient results, patient partner, patient healthcare authorities. And you can be a patient researcher, one of the most innovative paths for the future, I think. And you can be a patient coach, you can be patient consultant, advocate. So there are plenty of roles in the system. Where can we recruit patients? For example, in hospitals, in healthcare facilities, in universities, schools, healthcare authorities, research labs, startups, companies. More and more patient resource positions are being created in hospital. We are gradually moving away from voluntary work, which in no way reflects the contribution of a patient resource, to a real paid job. And last but not least, some patient resources are now collaborating with doctors to accompany complex cases of Lyme disease, and the results are highly positive for both patient and doctor. How patient results are trained in France, for example, it's recommended to follow a training course leading to a certificate or a diploma in order to become a patient resource or an engaged patient. And you need to complete at least the 40 hours patient therapeutic education modules. But you can also go for a masterclass, engage patients and regional healthcare institutes, for example. Or you can go for a full year in university degree in a health partnership, and at the Sorbonne, for example, or Paris 13. And each class of students is made up of half doctors and nurses and half patients, which is a very rewarding experience. But you can choose a complete university education with a bachelor's degree and a master's degree. In conclusion, integrating patient researchers into a study broadens one's perspective and takes into account elements not found in the scientific literature. And working with patient results on complex clinical cases allows for the consideration of items that are not visible and not always known for the doctor. And integrating patients involved in the definition of public health policies ensures that all the constraints and key aspects of the problem are taken into account. And I like this quote of Seneca: for the patients, life is not about waiting for the storm to pass, it's about learning to dance in the rain. Ready to try? Thank you. Thank you for your attention.